problems, we will start the session. This is Diabetic Retinopathy and Medical Retina session 4, which will be followed by semi-final. That is, the winners of all other 3 sessions will present here, and the winner will go to the next level, Colonel Rangachari. So we have with us Dr. Swarna Visaria Gupta. Dr. Devendra Vikram Singh has not come? No. Dr. Mantar Jogelkar, Dr. Rajinder Kaur Bottle, and Mayak Bansal has not come.
No.
So 4 of us are here. It is duration of each paper is 5 minutes. Time is important. There is a marking sheet given to us. So the time is important. Anything?
Changing of presenting author is not allowed.
Yeah, and membership number up to 28934 are ratified. So anyone outside this, if they are presenting, they can present, but will not be considered for the award. That's all. Okay. So if the presenting author is changed or some other person is presenting, it will not be considered for the award, but they can present. Probably they will get certificate also. So that is the thing. No. Yeah.
Results will be announced later, after, not after. So, Dr. Amit Kumar Dev is there. We'll move to the next paper. Dr. Anjali Maheshwari. We'll entertain, I think.
Later we'll
They may come
little late.
Yeah. If they don't find the hall.
Dr. Anjali Maheshwari. Yeah, she is a ratified member. The timer, please. Timer. All first day problems.
Kindly start it. Screen start karo. This one also.
Yeah. We'll just, after that, we'll start the timer.
We are already late. Kindly.
Beginning with half an hour delay. It's okay. This. Fine, no problem. Usually we don't allow questions from the floor. Because there are issues come with the all. Actually, we will not worry. That is their headache. We will try to finish. There will be 3-4 dropouts, most probably. So ultimately, we will be. We will start properly then. First day, first show, problem.
Nothing is coming here. You can start. Slides are not moving. Kindly see to. Timer, please.
Can anyone lend a pen?
I will just put.
Yeah, you can start.
Timer is not
Timer,
on, no?
timer.
These are all very competitive sessions, so we should not have any complaints. Or, they should put the timer there.
Actually, yeah.
No, they will put in the screen.
On the screen itself.
5 minutes each paper.
We are already very late. 5 minutes, 5 minutes.
By next session it will be smooth. We are only at the receiving.
वहाँ time भी आना चाहिए.
If she is getting the time, breakfast भी ठीक से नहीं किया.
बेल हो जाएगा. हाँ, ठीक है. वहाँ नहीं है, दिखाई देगा हमें टाइम. तो 4 minutes पे बेल बजेगी.
Total is 5 minutes, huh?
वो कह रहे हैं वहाँ दिखाई नहीं देता, लेकिन 4 minutes पे एक बेल हो. चलो, we can start.
4 minutes and 5 minutes. 2 bells, ना? 4 minutes में एक बार. Total 5 minutes में एक और बार.
फिर यहाँ पे टाइम्स अप हो जाएगा 5 minutes में स्क्रीन पे. स्क्रीन बंद हो जाएगा. ठीक है, we can start.
Total duration is 5 minutes per presentation. 4 minutes is just warning. No, 4 minutes warning, no? It's 5 minutes.
5 minutes.
A very warm good morning to everyone. I am Anjali Maheshwari, Retina Fellow at LV Prasad Eye Institute, and I'll be presenting on atypical unilateral retinal hemorrhages in a preterm infant, a diagnostic challenge. So, 3-month-old male child.
Slides are
Slides
not
not
moving.
moving. Kindly see to it. Please help her. Nothing is coming on her screen. Yeah.
Wait. They have to do. You will get full time. Don't worry. It is 5 minutes you will get. That's what.
Yeah, it's
Anjali.
Anjali. Dr. Anjali. Yeah, they'll correct.
They will do.
Yeah, they'll do. Yeah.
Timer again back to 5. Timer, can you change? Reset. 5, correct.
Now you can start.
Hopefully.
Yeah, start.
So I am Anjali Maheshwari, Retina Fellow from LV Prasad Eye Institute, and I will be presenting on atypical unilateral retinal hemorrhages in a preterm infant, a diagnostic challenge. So a 3-month-old male child with a birth weight of 1010 grams and a present weight of 2600 grams with a birth history of preterm delivery at gestational age of 30 weeks and C-section delivery, came with past history of undergoing anti-VEGF injection in both the eyes under the diagnosis of AROP, and he was referred to us for further treatment for retinopathy of prematurity recurrence. So on initial evaluation, as we can see in the fundus photograph, the right eye appeared like it had recurrence of the disease, but the left eye had no retinopathy of prematurity. But since it was unilateral in presentation, we thought of other causes of this presentation. So we went through the history, clinical examination, as well as the fundus photograph, and came to 3 differentials. First being ROP recurrence, second being hemorrhages secondary to any systemic cause, and third being any non-accidental injuries. The non-accidental injuries were ruled out after a thorough history and evaluation. But we went back to the fundus photo, and on careful looking, we see that there are these white-centered hemorrhages with multi-layered hemorrhages, and we can see that there is no tortuosity or dilatation of the blood vessels in the right eye. The left eye, on indented evaluation, we could see some peripheral persistent avascular retina. We advised a complete blood workup to rule out any other systemic cause. The hemoglobin was 7.6 gram%. The RBC count was 2.48 million per millimeter cube. And the platelet count was 2.40 lakhs per millimeter cube. So with this, with hemoglobin less than 10 gram%, we made a diagnosis of anemic retinopathy in right eye. And the patient was referred to pediatrician for further cardiac or thrombotic, to rule out any cardiac or thrombotic causes. The patient was started on oral ferrous ascorbate drops, and frequent follow-ups and monitoring was advised by the neonatologist. At 4 months after the first follow-up, the patient again presented to us with a hemoglobin of 12.3 gram%. And we can see this change in the 4-month follow-up photograph where all the hemorrhages have resolved except for the one which is in the superior temporal quadrant. And here at 6-month follow-up, we can see that there is no hemorrhages, and even the left eye had complete vascularization at this time. So the common signs of anemic retinopathy includes retinal hemorrhages, soft exudates, venous tortuosity, vitreous hemorrhage, or disc edema. So according to Sudhalkar et al., the most common causes of spontaneous vitreous hemorrhage in Indian subset includes vasculitis followed by hematological disorders. So anemia of prematurity can affect the outcome and course of ROP, and it can also mimic ROP in certain cases like ours. The implicating factors include internal factors like slow production of red blood cells or shorter lifespan, the external factors like blood loss, poor nutrition, and sepsis, and all these can aggravate low weight gain, poor oral intake, and apneic episodes, which in turn can aggravate anemia of prematurity. So, in conclusion, there is no substitute for a detailed history and in-depth clinical examination. And significance of timely and correct diagnosis helps in rationalizing treatment with multidisciplinary approach. Thank you.
Thank you, Dr. Anjali, for
Thank
taking time.
Yeah.
Any questions? Why is it unilateral?
So there are cases which have been reported in adults that it can present as unilateral retinopathy, even any systemic causes like anemia as well.
So, yeah, please. You go.
It was in the preterm.
It was in the preterm.
So have you taken any history of obstetric history?
So there was no maternal anemia or history of any sepsis. The child was born born by C-section, but we did do a thorough evaluation. The patient also underwent 2D echo and USG because we also wanted to rule out sepsis and other causes of these Roth spot that we could see. But everything turned out to be normal except for the blood workup, which had showed
See,
anemia.
simply by the hemoglobin, you cannot say it is anemia. You will have to do the ferritin, then oxygen concentration, everything.
Yes.
So how you can label it as a...
So the patient was referred to neonatologist, and they did an
He told.
Yes. So they did a thorough evaluation and workup, and after that the patient was started on oral ferrous ascorbate.
my dear, you told that she was on the anti-VGF.
So yes, she was injected before for AROP elsewhere before he came to us.
So before giving, what is the schedule of this? Can we start the anti-VGF in the beginning also only?
Yeah, so if the patient presents with bilateral aggressive retinopathy of prematurity, that's the first line of treatment that we give.
But this was having only unilateral.
No, that was before, like he presented to us 2 months after the injection. So, so after birth, he was diagnosed with AROP, given injection to treat it. But later again, when they saw that it's unilaterally occurring, they referred to us for further treatment like laser or any further injection.
So anemia of prematurity is not uncommon disease.
Yes.
So how many patients of your ROP are having anemia of prematurity? You have any records, and how many of them present like this?
So there was a study by Lee et al. So which showed that 28% do present with anemia of prematurity and then retinopathy, but it can get aggravated with thrombocytopenia if it is additionally present.
So why in this case and why one eye? That's what is your thoughts?
Yeah, so that was also something we were also wondering, because anemia is systemic, as a systemic disease, should present bilaterally, but we went through the literature and there was not much literature in infants, but we saw the literature on adults. There are few cases which are reported to have unilateral causes, but again, the cause or the pathophysiology for the unilateral presentation is not something that we are aware of.
Anti-VEGF injection was given bilaterally.
Yes, both
so
eyes.
it means one eye may have responded well to the anti-VEGF,
Yes.
and other
Maybe
anemia
those.
added to the
Yes.
that may be the cause.
Maybe.
Good case.
Thank you.
Next person is Aditi Anil Kumar. Can you just put the presentation, Aditi Anil Kumar?
Good morning, everyone. I'm Dr. Aditi, and my paper is on impact of consanguinity in prevalence, severity, socioeconomic burden in Rett dystrophies. So consanguinity is a union between couples with a common ancestor. It is not an uncommon practice in India. The prevalence rate is up to 9.9%. Why is it socially favored? Because it may enforce couple stability. There are some hidden uncertainties in terms of health and financial issues, and it may strengthen family ties. So most of the retinal dystrophies are autosomal recessive, and consanguinity increases the disease burden of some of these diseases. So AIM, as I previously mentioned, this is a retrospective observational study of 5,108 patients between January 2016 and January 2025. A standard consent was obtained for data sharing, and also a short survey was done with 40 patients to understand socio-economic burden of the disease. They all underwent a comprehensive ophthalmic examination with pedigree chart, which was hand-drawn based on recall. They underwent relevant investigations and electrophysiological studies and genetic counseling and testing wherever possible. Moving on to results, so data retrieval and processing was based on an Excel sheet where data was segregated and processed. Total patients were 5,108. 39% of them were females, 61% were males, and the mean age was about 31.59. The dystrophies that we came across were these. So, at least 75% of them had at least one consanguineous marriage in the family, and about a whopping 20% had two consanguineous marriages in the family. And most of them were second degree consanguineous. And as far as generations of consanguinity is concerned, 81% had at least one generation, 17% had two, and about 2% had 3 generations of consanguinity. So individually looking at it, 47% in RP, 43% in Stargardt's, 25% in cone dystrophies, 53 in Conrod, Rod cone had 60, Lieber's had 69, macula had 25%, and the rest of it, 66% of consanguinity out of the total numbers. So what is more alarming here is even with one affected member, about 10.2% still went on to marry consanguinously, and about 0.3% with 3 affected members went on to marry consanguinously. So let's look at this case of a 24-year-old newly married woman who is got decreased vision in the left eye compared to the right eye since childhood. She's already a diagnosed case of retinitis pigmentosa, and she was interested in family planning. So the vision is 6/9 and 6 in both the eyes, clinically classical RP picture, and the OCT also confirms the same with a subfoveal EZ preservation. This is the pedigree chart of the lady. She was born out of a consanguineous marriage and still went on to marry consanguinously. This is the genetic testing of the patient. She had a CNGB1 mutation. And when we looked at her brother and husband, both of them also had defective genes. So we counseled her for the same, about the same. There was a short survey looking at the impact of mental health, financial issues, negative social aspects, negative aspects on social life. And all of them had 55% turned out to have mental health issues. 72% of them told us that all these conditions are leading to financial issues also, and it also impacted their social life. So in spite of telling them about the hazards of this, only 10% agreed to undergo genetic counseling, and it is a huge emotional and psychological burden. The preferences of consanguineous marriages is primarily based on social and cultural factors. So what this study adds is, it shows the South Indian data on the impact of consanguinity in retinal dystrophies. There is a huge lack of awareness about genetic counseling, the inheritance patterns, and the impact it has on various levels. So these are my recommendations. Thank you.
Yeah, thank you.
Very nice presentation and
Thank
very
you,
vast study.
Thank you, ma'am.
But one thing is there, have you looked for the risk factors also in these patients? Apart from the genetics or the consanguinity, any toxic or the food habits? Or
Yeah, so the entire detailed history is taken, ma'am. So the consanguinity just forms, say, around the percentages I showed individually. The other subset of patients have different issues. And I mean, some are spontaneous, some are sporadic cases, all of that, yes.
And in all the patients you did the genetic
Those
study?
who agree to it. So it is such deeply rooted in the social custom that it's very difficult to get them to counseling and then to genetic testing. So not many agree.
Genetic testing is very, very costly.
Yeah.
So it is
Yes. So at least to counsel them in terms of when they already know they have an affected member in the family. So it is always better to give them information regarding the same and what are the possible risks. At least that part can be done from our end, because some of these diseases are potentially blinding too. So our bit, whatever possible from our end, can be done. At least an awareness so that these practices slowly die away or fade off.
This
over time.
the patients included were all non-case of RP, Stargardt's, like that. Or
So
general
they are referred to us. They are initially
No, in this
diagnosed by
study,
us.
yeah,
All entire.
And there
All 5,000 are dystrophies.
dystrophies.
All
So
dystrophies.
actually, this may be a under evaluation, like prevalence of diabetic retinopathy in non-diabetic. There is a big undiagnosed diabetes, or something like that. So the impact may be more.
In fact, more. So
Yeah.
we can say, based on the cases that we receive over the last 8 years.
Yes, yes.
Dr. Varnika Aditi Singh also can come and get ready. Varnika Aditi Singh.
So,
Dr. Subhadra.
yeah. You can stay.
Oh, I just wanted to, there's no question for her, but I just wanted to comment on the cost. So because I am in the genetic field for many years, the cost has drastically come down. Currently, it is costing about 15,000 for the screening test. So patients, if they undergo cesarean section, it costs 50,000. So also there are organizations which are donating now, especially the patients are donating for others to undergo genetic testing because they want a pool of patients to have that genetic test positive so that the treatments can come. Government of India also now providing for rare diseases. So I think we should all look at those options and try to get the genetics done. It's not all that impossible, which was 10 years ago.
Yeah, absolutely.
That's
No, in our,
Everywhere,
this is
everywhere.
also
Even
everywhere,
in
and it
our
is
place we
because
are
it's
doing.
not only for the eye. Now genetic testing is being done for so many diseases that the cost of genetics, everything has come down. And previously we didn't have genetic counselors. Now that is open to non-doctors, and so now we have a lot of genetic counselors also trained people. So I think the field is rapidly expanding,
Ma'am, I
and now
want
it
to
is
ask
available.
just to know from you
Varnika.
that if
The-
some patient come of
Varnika.
retinitis pigmentosa comes, and then specific gene should be asked or the whole counseling for retinitis.
We leave it to the genetic counselor.
Okay.
We are not experts. What we explain to the
Think we
patient
are
is the
running
importance,
short of
and
time.
then the
Yeah.
genetic counselor decides what test to be done. That is very important. We should not tell what, because
Okay, which gene should be-
what post-test counseling also has to be done by them only.
Okay.
Thank you, madam.
We have sessions on this. People can attend.
Yeah. Thank you. So, Dr. Varnika Didi Singh is ready. When the presentation is getting over, the next person after this, Dr. Avdesholi. Yeah, he's the.
Good morning, everyone. Today I will be presenting a very interesting case in which our clinical examination and investigation helped in clinching a systemic diagnosis of the patient and partly helped in saving the life of the patient. There are no conflicts of interest or financial disclosures. Systemic lupus erythematosus is an autoimmune disease with multisystemic involvement, and the ocular manifestations affect around 33 to 50% of the patients, ranging from keratoconjunctivitis sicca to vision-threatening manifestations like lupus retinopathy and optic neuritis. Both the conditions of lupus retinopathy and optic neuritis together have rarely been reported in literature. So I am presenting the case of a 45-year-old female, known case of hypertension and tetralogy of Fallot, presenting to the emergency with complaint of inability to bear down weight on bilateral lower limbs with generalized weakness of body, along with sudden profound painful diminution of vision in right eye for 1 day. So on the journal physical examination, the patient was conscious but delirious. The patient was wheelchair bound because of the inability to bear down weight and was diagnosed with sudden onset flaccid quadriparesis. The patient was febrile at the presentation and her blood pressure was well controlled with medication. On ophthalmic examination, at presentation, the right eye had perception of light, but projection of rays was inaccurate. Relative afferent pupillary defect was present. There were painful eye movements. Anterior segment and intraocular pressure were within normal limits. On posterior segment examination, in the right eye, there was presence of disc edema with dilated and tortuous retinal veins with perivascular flame-shaped retinal hemorrhages. There was presence of attenuated arterioles with presence of cattle tracking in the arteries and presence of an occluded arteriole with retinal ischemic whitening and a cherry red spot at the macula. The left eye was essentially normal. Fundus fluorescein angiography showed markedly attenuated vessels, delayed arteriovenous transit time, ischemia of the macula with capillary non-perfusion with dye arrest at about 1 disc diameter away from the disc. So summarizing my case, it was a 45-year-old female, known case of hypertension and tetralogy of Fallot, presenting to the emergency with clinical features of quadriparesis and simultaneous sudden profound diminution of vision in the right eye. The ophthalmic examination was consistent with central retinal artery and vein occlusion with gross macular ischemia. Based upon the age and the clinical presentation, multiple differential diagnoses were kept. Autoimmune diseases like SLE, APLA, and Behçet's disease, systemic vasculitis like polyarteritis nodosa, thrombophilic disorders including polycythemia, hyperviscosity blood disorders like hyperhomocystinemia, and systemic metabolic conditions like atherosclerosis, hypertension, hyperlipidemia, and diabetes. Laboratory investigations were done. The routine blood investigations for coagulation, special tests for coagulation, and the serological test, CSF analysis came out to be normal. Blood inflammatory markers, including the C-reactive protein, were raised, indicating an underlying inflammatory process. In the autoimmune disease workup, anti-nuclear
ANA was positive with a nuclear pattern, and the anti-double-stranded DNA test also came out to be raised. The two-dimensional echo was consistent with presence of tetralogy of halo, but did not show any vegetations or embolic material on any of the heart valves, excluding it as the cause, and the carotid Doppler was within normal limits. MRI sequence showed a bulky right optic nerve with post-contrast enhancement of the optic nerve sheath suggestive of optic neuritis. Provisional diagnosis of SLE was kept, and based upon the European League Against Rheumatism, American College of Rheumatology classification criteria for SLE, the final diagnosis of combined central retinal vein occlusion and optic neuritis with quadriparesis in a case of systemic lupus erythematosus was kept. The patient was given high-dose pulse steroids, that is methylprednisolone 1 gram daily for 3 days, followed by 1 milligram per kg oral steroids and oral anticoagulant therapy, resulting in progressive systemic improvement. Right eye intravitreal anti-VEGF bevacizumab and panretinal photocoagulation was done because of the high risk of neovascularization due to the continuous hypoxia from the occlusion. On 2 months follow-up, there was presence of optic atrophy with the sclerosed retinal vessels and absorbed retinal hemorrhages, but no evidence of neovascularization, and OCT showed complete atrophy of the inner retinal layers. So the combined occlusion in SLE is attributed to the deposition of immune complexes in the vessel wall, resulting in release of inflammatory mediators, or maybe because of the development of Aplar syndrome. Optic neuritis affect around 1% of the patients due to vasculitis or thrombotic vasoocclusive phenomena, resulting in axonal necrosis. The index case is a severe form of SLE presenting with multi-organ thrombi formation. Concluding my case, the combined CRO-CRVO as the initial presentation of lupus retinopathy with optic neuritis is, as seen in our case, is extremely rare. Thorough workup is essential. Immunosuppression with addition of anticoagulation should be done. PRP and anti-VEGF are the first line agent. Visual recovery has only been reported in few cases, likely due to retinal ischemia. Thank you.
So any association of tetralogy with SLE you have noted in the literature or something? Tetralogy of Fallot and SLE, there is no association?
No association.
Any genetic or commonalities
No,
or not?
no.
And I think the flaccid paralysis is not diagnostic of the SLE. So it may be associated. So have you inquired about the drugs? Some drugs are also producing these symptoms. Iatrogenic.
But she was not on medication except for antihypertensives, not on any other medication. MRI spine was also done. It showed microthrombi formation. Rest was within normal limits.
So, thank you, Dr. Varnika. We will go to Professor Avdesh Oli for his talk on role of suprachoroidal triamcinolone and hyperbaric oxygen therapy for CME and RP.
Can I have my slides, please?
I think the participants have to sign in a paper. Somebody can. Yeah, and they will take them across. They have to sign, no? This is what? He is Professor Avdesh Oli, no?
Avdesh.
Professor Avdesh Oli, he is the previous one. He is standing. This is the wrong one.
Avdesh. Yes.
Yeah.
Good morning, everyone. So I'll be presenting on role of suprachoroidal triamcinolone and hyperbaric oxygen therapy for macular edema in retinitis pigmentosa. So as we all know, macular edema is important cause of central vision defect in retinitis pigmentosa. There are multiple therapeutic modalities which have been tried but very limited success. Most recently, steroids in the form of Ozurdex implant and PST has been tried, but because of their high cost and increased side effects, there are newer modalities which are coming like suprachoroidal triamcinolone, which has been recently tried in various etiologies of macular edema with good success. Also, there is a sparse literature on use of hyperbaric oxygen therapy, and it has been shown to be efficacious, but those cases are very few. So this report investigates the potential benefit of adjuvant role of suprachoroidal triamcinolone and hyperbaric oxygen therapy. So my case is a 35-year-old male serving soldier. He presented with diminution of vision in both his eyes for last 10 years, and recently he started having metamorphopsia, and his visual acuity dropped to 6/36 in both the eyes. The fundus examination revealed a classical RP type of picture wherein there was arterial attenuation and deposition of these bony corpuscular pigments. His optical coherence tomography showed macular edema in both the eyes with intraretinal fluid and cystic spaces. And a fundus fluorescent angiography confirmed this cystoid macular edema. He had extinguished ERG waves and had hardly any central vision and peripheral vision left. So as he felt, though the vision was equal in both the eyes, but he felt left eye was not that good. So so we tried suprachoroidal triamcinolone in the left eye, and this we did with our innovative technique, which was described almost 2 years back. It is published in IJO, and it has been tried in various other diseases. So here what we do, we take a 26 gauge needle and we take outer sheath of a 22 gauge cannula, so that we can make a needle where just the beveled end, which is roughly around 1 millimeters or 900 microns, is exposed. This is later confirmed with the help of calipers, so that the only beveled part goes in when we inject the drug. So like a standard injection procedure, we clean and drape the eye, and then we mark 4 millimeters from the limbus. We can go slightly posterior also. And then with the help of this needle with 4 milligram of triamcinolone in 0.1 ml, we go perpendicular to the sclera and we apply gentle pressure so that there is a small dimple on the sclera, and then effortlessly we inject the drug into the suprachoroidal space. The only other precaution you have to take, that the beveled part of the needle should be pointing posteriorly so that the drug can effortlessly diffuse posteriorly. So this is the OCT of the left eye done after 24 hours of the injection, and you can see already the suprachoroidal triamcinolone has started showing its effect, wherein the macular edema has reduced in the left eye, and this is the anterior segment OCT where we confirm the location of the drug in the suprachoroidal space. So this patient, along with suprachoroidal triamcinolone, underwent 10 sessions of hyperbaric oxygen therapy. We are lucky because we have a center who deals with aerospace medicine. So he was given, as per the protocol, 10 sessions of hyperbaric oxygen, and then he was regularly followed up for 1 year. Left eye, which had received suprachoroidal triamcinolone along with hyperbaric oxygen, maintained improved earlier and maintained a vision of 6/9 till 1 year. So this is pre and post in the left eye after hyperbaric oxygen therapy and injection 4 milligram of suprachoroidal triamcinolone. This is a comparative OCT at the baseline and at the end of 6 months. So the mechanism of hyperbaric oxygen therapy, though it is not fully understood, but physiologically it is when we increase the oxygen concentration of the dissolved oxygen in the plasma, there is better tissue oxygenation of RP pump. However, more trials are required. Similarly, suprachoroidal triamcinolone is because of the targeted delivery of the drug. The side effect profile is very less as it has been shown in various trials, and this case demonstrates successful management of macular edema in RP combining these two therapies. Thank you.
How many cases you had?
This was one case which I have documented, but after that we have followed up 2 other cases also with good results, sir.
Is it due to the triamcinolone or due to hyperbaric oxygen?
Sir, I think it is the effect of both, wherein the triamcinolone has an adjuvant role because the left eye, which was the eye where we had done the intervention, the vision improved faster in that, and the quality of vision was maintained till 1 year follow-up.
That is the improvement in macular edema was more in the combination.
Yes, sir. In the
than
combination.
other.
Yes, sir.
Any improvement in fields was seen?
Field, there was no significant improvement in ERG or the fields, but central vision, the quality of vision was good. There was no metamorphopsia.
Any effect of hyperbaric on the brain,
On the ma'am?
in the central nervous system, brain?
On the in the right eye, the vision had improved. The macular edema had reduced, but it started recurring at the end of 1 year, whereas in the left eye, the macular thickness was maintained.
No, she wants to ask any systemic effects of this hyperbaric
No,
oxygen.
there was no systemic side effects because all these patients, they were before undergoing hyperbaric therapy, they are screened for any ENT or any other potential complications which can arrive. So pre-hyperbaric oxygen therapy, we rule out all those diseases if there are any risk factors for any complications. So in this case, there was no complication.
Because it is mentioned in the literature also, hyperbaric oxygen causes some cerebral infarcts
Okay.
in the brain.
So,
That's why I asked.
but in our center, we have a hyperbaric chamber, and for various diseases like non-healing ulcers, diabetic foods, we keep giving. So I'm not really aware that whether there are any side effects because procedure screening is important in all these cases. Maybe high-risk cases would develop all those complications.
And one thing more, did you compare this suprachoroidal triamcinolone with the subtendons, posterior subtendons?
Not in this case, but in other cases we have compared, and the incidence of increased IOP is more in subtenon, plus the efficacy is also not that fantastic as it is seen in macular edema with suprachoroidal injections. And the advantage of this technique is that it can be done with the easily available sterile material in our ORs, and the hindrance of using patented catheters and needles, that is not there in this technique.
What are the chances of perforation while giving this injection?
I would have given more than 200, 300 injections in various conditions, but once you calibrate and you just make sure that only 900 to 1 millimeter of the beveled edge is exposed, I don't think there is any chance. But yes, theoretically in high myopes where the sclera could be thinner, there could be a theoretical risk.
You can try a microperimetry over the macula,
yes.
So that you can demonstrate the increase in improvement
Yes.
in macula.
Maybe
Because fields are
further-
not that sensitive
Yes.
for normal fields.
Yes.
Thank you, Dr. Avdesh. So I invite Dr. Burgohain for the next presentation.
Good morning, everyone. So recently we have all been fascinated by the Studio Ghibli images that have been trending. So I'm here to present on another aspect of machine learning that we can use in ophthalmology. So my topic is transfer learning capabilities in artificial intelligence in ophthalmology. There are no financial disclosures. Traditional machine learning techniques are resource intensive and time consuming. Alternative machine learning techniques such as transfer learning can help us overcome this. Transfer learning is basically machine learning technique where a pre-trained model on a larger data set is retrained on a smaller data set for a task which is related but different. By this technique, we skip a lot of steps that are involved in traditional machine learning, thereby reducing time and cost. So the purpose of our study was to make a machine learning model using transfer learning for fundus and optical coherence tomography image classification. We used 572 OCT images with source label of age-related macular degeneration, central serous retinopathy, macular hole, diabetic retinopathy, and normal scans. We also used 400 fundus images to classify diabetic retinopathy. We used machine learning platforms provided by Apple, Google, Clarify, and MedicMind. And we used a paired t-test to statistically compare between the models. Coming to the results, the Google models showed an average accuracy of 0.97 with a precision and recall of 98.21%. You can see the precision recall curves in the figure. The Apple model had a test accuracy of 64% with an F1 score, which was highest, 0.78 for macular hole, and it was lowest for central serous retinopathy, which was 0.57. The Clarify model had an average accuracy of 0.95, and our highest F1 score was for normal OCT scans, that was 0.98. Coming to the MedicMind model, which was used to classify diabetic retinopathy images, it had an average accuracy of 0.72 and an ROC curve area of 0.75. Now, we also compared the models between Apple and Clarify, and it had a value of t-test, p-value of 0.768, which was not significant. Using transfer learning, we significantly reduced the computational cost and time that was required. All the models that we trained had competent accuracy scores. The Google and Clarify model had a non-significant advantage, which could be due to their cloud computing that was used. MedicMind model for diabetic retinopathy showed an accuracy of 72.5%, and it also highlighted the challenges that we have with fundus image classification in comparison to OCT scans. The models were not statistically different, so it highlights that cloud-based computing and local hardware utilization did not make much difference. So how is this useful clinically? In medical science, we can see that there can be racial disparities due to the data that we have. So transfer learning can be used for improving the predictions of ophthalmic diseases in a group that is disadvantaged due to the number of data that is available. And this can be used from a data abundant group. These findings also tell us that limited data sets can be used to improve model predictions. To conclude, transfer learning reduced the computational cost and time. It also showed that there was no statistical difference between the models that were used, that is between cloud-based and local hardware-based. And all of these also suggest that we can use limited data using transfer learning to develop machine learning models. Thank you.
Can you just explain what is the difference between machine learning and transfer learning?
So transfer learning basically is a technique in machine learning.
Okay.
So traditional machine learning, we have a lot of steps. We have to collect data. We have to train a model from scratch. So but transfer learning is basically using one that has already been trained on, let's say, a model that is designed to identify images of humans, people's faces. So we repurpose them to identify OCT images or let's say fundus images. So we help reduce that cost, which is used to train the model from scratch from that bulk data set that was already
The
used.
accuracy will be less than the...
Sorry, sir?
Accuracy will be, precision will be less than actual machine.
Yeah, it will be definitely be lesser than the model that is specifically trained for that purpose, but we have competent models that can be developed.
You haven't compared transfer learning with normal learning.
No, I couldn't compare because the data was not available. Basically.
And which transfer you actually used?
I have used for models of Apple.
You said you have used a trained database from
Yes,
other
sir.
thing. Which
Yes.
one was that?
No, the models that are
What
already
model you used to transfer it here?
that was in Google, that was from Apple. These are already trained models.
On what? On what? That's what I'm asking.
Like I said, for
you don't
facial
have-
images, for
No, but you don't have any specific.
yeah,
idea.
specific data I don't have, sir, because it's not mentioned in the website. So, ma'am, deep learning is basically it's the same, but transfer learning, we are skipping those steps that are needed. Already a model has been trained on deep learning, and then we are using that same model for a different purpose. Retraining them, basically.
Irrespective of any type of the equipment, as OCT is there, so many models are there.
Yes, sir.
Use anyone.
Yes, sir. Yes, sir.
Any transfer learning app, this has been approved by FDA for
Not yet,
nothing,
sir.
no? Okay,
Yes, sir.
thank you.
Thanks, sir.
Thank you. So I think the next presentation is Dr. Shravya Karna.
Dr. Shavya Karna. I think she is not here.
Dr.
Shravya Karna.
Shravya Karna is here? No.
So next is Dr. Sheetal.
Dr. Sheetal. Dr. Sheetal Bajoria. Octa features in. Just load the presentation. Just at the end we will mark.
Good morning, everyone.
It's okay. 3 more are there. We will.
Slide
Aram se.
Please make it on slideshare. Okay. Oh, can you reset the timer? Good morning, everyone. I'm Dr. Sheetal Bajoria. My paper is on OCTA, optical coherence tomography angiography, features seen in hypertensive patients. Systemic hypertension remains the leading contributor to the global burden of disease and global cause of mortality, leading to 9.4 million deaths and 212 million lost healthy life years each year. In 2015, around 874 million adults had systolic blood pressure of 140 mm of mercury or higher globally. Systemic hypertension, as we know, it damages the body's microvasculature, leading to target end organ damage, which includes cerebrovascular accidents, cardiovascular disease, renal failure, and retinal vascular diseases. The retina is highly vascularized tissue which is susceptible to microvascular damage due to hypertension, and retinal imaging provides a unique opportunity to non-invasively assess and diagnose these pathological changes. The current system of grading hypertensive retinopathy are the Geith-Wagner-Barker or Wong-Michel's classification system, which is basically based on clinician subjective assessment of retinal fundus photograph. So, OCTA provides a non-invasive method to see the retina. Changes on OCTA in hypertension compared to normal. Here is the photo showing comparison of OCTA in normal person and in hypertensive patient. Here we can see that there is increase in FZ area, the blue zone, in both superficial and deep capillary plexus in systemic hypertension compared to the normal. My study, the purpose was at the macula, a study analyzed vessel density at the superficial capillary plexus, FZ area, vascular density in central fovea and parafoveal region in hypertensive patients. It is a retrospective observational study on 100 eyes of 55 patients. It is an institutional study. Out of 55 patients, 100 eyes were included and 10 eyes were excluded. Inclusion criteria were systemic hypertension since 1 to 20 years and above, but without hypertensive retinopathy. Hypertensive patients on regular antihypertensive. Basically, patients without development of retinopathy changes like CRVO. Exclusion criteria were cases without pre-existing hypertensive retinopathy, RVO, age less than 18 years, cases with glaucoma, cataract, other retinal pathology, and diabetes mellitus. All data were measured using NGOV system already installed in OCTA software of OCT machine, where 6x6 mm cube was studied. Main outcome measured were the mean FZ, mean central vascular density, and FZ correlation with central vascular density, and other parameters were done. Statistical analysis were done using IBM SPSS 20.0 statistical analysis software. Here is the photo where OCTA image of superficial capillary plexus is seen. Here we can see that the yellow area shows the FZ, and the left corner the magnified image. This is the angioplex matrix where we can see the FZ and central vascular density. FZ area is 0.44 mm square and central vascular density is 23.9%. So the descriptive statistics, mean age was 59.6, that is around 60 years. Mean FZ was 0.34 mm square and mean central density was 17.85%. This is the photo showing the significant correlation of FZ with age and central vascular density with FZ. So FZ shows significant negative correlation with central vascular density with p-value less than 0.01.
And it also shows significant negative correlation with age, with p-value less than 0.05. However, this is a very important finding where no significant correlation was found between duration of hypertension and FSZ and central vascular density. So for conclusion, FSZ area widens in hypertensive patients with decrease in the central vascular density of superficial capillary plexus on octa. With an increase in age, FSZ decrease in size, and duration of hypertension does not affect the FSZ and central vascular density if hypertension is under well control. Clinical implication, it is important to undergo baseline octa scan in hypertensive patients. So the take home message is our study helps in determining the role of octa in determining microvascular changes seen in hypertensive patient without the use of intravenous dye, unlike FFA. Also, it helps in early detection of widening of FSZ, changes in the vascular density of macula in hypertensive patients before the actual clinical appearance of hypertensive retinopathy as seen on fundus examination. So octa provides non-invasive option of visualizing the retinal vasculature, that too within seconds. A study reveals that widening of FSZ and decrease in central vascular density forms early octa biomarkers in hypertension. Thank you.
You didn't include a normal database for normal patients,
Sir,
non-hypertensive patients.
Sir, no, we did
Only,
the study only on hypertensive patients. Sir, ma'am, it is an observational study, it is not a comparative data.
Just one comment. Actually, some of the conclusions cannot be achieved from your small set of 100 patients.
Yes,
the
sir, we
control of
need,
hypertension caused less changes. How do you know that they have been controlled? So, I mean, it's not a.
It's
Sir,
a
we need,
longitudinal
some of the
study.
conclusions are not. You cannot extrapolate from your this thing.
So it is a observational study. We need a longer study. It is done only on 100 eyes.
You should have added a slide of limitations of your study.
Limitations. Ma'am, one thing is it is a costly study. I mean, octa is, since we are blessed with a institute where we have octa scan available, but I would say that in private setup it is difficult for patients to pay for octa scan. But definitely it is better as it is not dependent on dye, and patients with renal impairment and pregnancy where FFA is contraindicated, we can definitely go for octa scan. Yeah.
Thank you, Dr. Sheetal.
Thank you, sir.
Just calling once again, three people who have not come. Dr. Amit Kumar Dev, not there. Dr. Shravya Karna, not there. Now we'll go to the last one. Dr. Akansha Pandit is here. Dr. Akansha Pandit is also not here.
So we conclude this
session, but there is a semi-final along with this. That is, madam. I hope the winners of the previous sessions, Dr. Garyasri is here. Okay, Dr. Azhar Mohammed Yusuf. Great. Dr. Nikita Gupta. All three are here. So this is the winners of the previous sessions of diabetic retinopathy and medical retina 1, 2 and 3. They will also present here. And the total winner will go to the next level, Colonel Ragachari, I think. So that is it. So I will invite her. Garyasri, Dr. Garyasri. These three people, it is ready, no? Yours also is there in this, sir?
Guest talk. Guest talk. She is having guest talk.
It's a talk. Yeah, we'll do. No, we'll start. Yeah. Free paper only 3 are there. No?
All 3 are there.
We will finish and then only next person will come. That we have decided.
So she will
Yeah.
present first?
Yeah, yeah.
Whichever, or they are getting ready already.
They're getting ready.
After the free paper.
Other 3 papers. So.
We have a talk also after this.
By Kanika.
Yeah. So next is Dr. Garyasri, who is presenting on ocular blood flow as preclinical marker in diabetic retinopathy.
Good morning, everyone.
Slides. Yeah.
I am Dr. Garyashi, and I shall be presenting before you the topic ocular blood flow as a preclinical marker in diabetic retinopathy. So in the early 2000s, we have noticed several studies which investigated the relation of ocular blood flow with different eye diseases. Similarly, we have conducted a study to establish any correlation between diabetic retinopathy, which basically affects the retinal microvasculature, along with the retrobulbar circulation. So the main aim of the study was to assess the parameters in the retrobulbar vessels using a non-invasive technique that is color Doppler imaging. And we would reassess the parameters after a period of 6 months and try to establish if there is a correlation with the progression of the disease. So this was a hospital-based observational study conducted in a medical college in Assam, where we had taken 120 diabetic patients more than 40 years of age with or without retinopathy who were willing to participate in the study. However, patients who were metabolically unstable such that they are not able to follow up for the subsequent visits, or they have any disease or vascular anomaly of the eye, history of trauma, or any other significant media opacities that precluded the fundus examination were excluded from the study. Briefly about the methodology, all the patients more than 40 years of age were recruited. A detailed history was taken, clinical examination was done, and a dilated fundus examination along with a digital fundus photo was documented for each and every patient. The patients were then classified according to the International Disease Severity Scale, and also they were subjected to color Doppler imaging where different parameters were assessed. So here we can see on the right hand side we have the digital fundus photographs, and on the left hand side we can see the color Doppler imaging. This is a very easy, less time consuming and affordable test where we can assess the parameters, and we can see different parameters on the left hand side, including the peak systolic velocity and diastolic velocity, the resistivity index and the pulsatility index. However, in the study only the resistivity index was significant, so we'll be discussing only on that. Coming to the results, 120 patients were included, majority of them were males, and most of the patients had a duration of diabetes for more than 13 years. Most of them had moderate NPDR changes. So what we found was in the ophthalmic artery as well as the central retinal artery, we can see a significant increase in the resistivity index. These values were compared over a period of 6 months. So we have seen similar articles in the literature where we have seen Dimitrova had also studied 18 patients for 21 months, but he could not establish any significant alteration. But we have seen significant increase in the resistivity indexes in the central retinal artery by a study conducted by Sood et al. And there is only one long-term study in this field conducted by Neudorfer M, where he has seen significant increase in the RI in the ophthalmic artery. However, the study has several limitations, which is a small sample size, and the follow-up period is very small to establish progression of diabetic retinopathy, to establish a correlation. The main idea of presenting this presentation here is to garner the audience so that this can be conducted across large population and different healthcare settings, and hopefully in the future we can also have a non-invasive affordable technique as a regular checkup for diabetic retinopathy. Thank you so much. These are my references.
My dear, progression of diabetes
Yes,
is
ma'am.
not only due to the glycemic index.
Yes, ma'am.
Actually, other comorbidities, dyslipidemia and everything there.
Yes,
so have
ma'am.
you accounted for this?
No, ma'am. It was only the progression here was defined as increase in the grading or increase in the next progression to the next grade, or at all in the same grade but more clinical presentation. That is how it was
So
taken account.
it was only these patients were of simple diabetes, having nothing like the cholesterol or anything.
Those systemic associations were not
Undertaken.
Yes, ma'am, undertaken.
This color Doppler was used the same ordinary machine or any additional?
So that was a ordinary Samsung ordinary ultrasound machine using the 15 megahertz transducer. Only we had to use the color Doppler mode, and the parameters will be automatically reflected. No, nothing, sir. So it would cost around 800 for the patient.
It was done by ophthalmology department or radiology department?
I took help of radiologist, ma'am.
Okay.
Development of macular edema was considered as a progression, or?
No, sir. Any change to the next grade of
just degree
diabetic
of,
retinopathy, or even within the same group with more hemorrhages or more symptoms, but not accounting to the next group, were considered as progression.
Did you
sir.
compare the two eyes and difference between the
No, sir.
progression?
Only
into
the one eye was taken, which had severe presentation. Only that eye was taken, sir.
Yeah.
Next one we can contact.
Yeah.
Thank you.
Thank you.
Dr. Asar Muhammad Yusuf Sheikh, I invite Dr. Asar Muhammad Yusuf for the next talk on role of healthcare management for screening diabetic retinopathy in rural India.
नहीं लास्ट का नहीं लेंगे, इस सेशन का they will calculate whoever is the winner. And then they will write.
Very good morning to all. This is an interventional study which was carried out during my MBA thesis program from BITS Pilani. The role of healthcare management for screening of diabetic retinopathy in rural India. It was a pilot study. The study was carried out in association with the Queen Elizabeth Diamond Jubilee Trust, UK, the London School of Hygiene and Tropical Medicine, Indian Institute of Public Health, Hyderabad, Government of Maharashtra, NPCBVI, and Department of Ophthalmology, MJMS. Diabetic retinopathy screening guidelines prepared by the AIOS Task Force Committee and the Vitreoretinal Society of India provides a framework for DR screening that is currently feasible in India. The present study helped in assessing the impact of healthcare management with the help of using this guideline practically among the rural Indian population in state of Maharashtra. As a clinician point of view, timely screening is at most important for prevention of blindness in diabetic patient, but this study also emphasized on healthcare management intervention in making optimal DR screening with amalgamation of recruitment, training, orientation of healthcare workers, data management, dynamic referral system, and use of technology. Aim to study the impact of healthcare management intervention in screening of DR in government health facility, to recruit ophthalmic officer from healthcare facility and train them for use of non-mediatic fundus camera, teleophthalmology, and AI software for screening, to train and orient the healthcare worker for streamlining of DR screening. This is a prospective interventional study conducted at 5 government health facility of 5 blocks in district, which included initial 1 year followed by 4th month of screening with intervention. The following are the healthcare intervention carried out. Number 1, education and training of the village health worker like ASHAs, ANMs, midwifery, NCD staff, and paramedical ophthalmic assistants by creating awareness in DM patient using pamphlet and information booklet which were given in local vernacular language. By creating awareness by displaying poster message in the local language in NCD clinic and eye clinic waiting areas. Training of the NCD staff and PMOA for using non-magnetic fundus camera and online DR screening software. DR screening was done at the government health facility and not at the CHC also, but at PHC and even at the sub-center level. In this, non-magnetic fundus camera were used by the PMOA or the NCD staff. And provision of transport to diabetic patient from village to the PHC for DR screening, which was done with the help of the healthcare workers. Data entry was done on the diabetic retinopathy clinical performa and online DR softwares. Reporting of all these photographs from the DR database by ophthalmic surgeon at the base hospital, sending the respective government health facility via teleophthalmology. All the patients with DR were referred to the base hospital and were treated with taking fundus photographs, FFAs, panretinal photocoagulation was done, intravitreal injection and vitreoretinal surgery was done. In phase 1, 2,794 known diabetic patients were screened, which is approximately 20% of the 13,890 registered diabetic patients in the 5 block. And the phase 2, where the intervention was applied only in the 4 block, remaining one as a control, 590 ASHA workers were trained, 9 paramedical officers were trained for taking for photograph and use of teleophthalmology, in which 2,210, which amounts for 16% of the diabetic population, were screened. You can see a spike in the number of patients screened with the intervention in the last 4 months in the 4 block and decline in the control block. This is a trend of the screening data. Total 5,004 patients were screened, out of which 375 were referred and 81 patients were treated. You can see that the referral is maximum in the blocks where intervention was done. Total 8776 eyes in which fundus photographs were gradable. 668 shows diabetic retinopathy changes with prevalence of 7.62%. These are the number of investigation and management numbers given in the tables. So the present study highlights the important role of following healthcare management intervention by diabetic retinopathy screening at the government health facility, education and training of the village health worker, DR screening with non-mediatic fundus camera by trained PMOA, dynamic referral system, use of data entry storage software, cloud computing, use of teleophthalmology, and further management referral to the base hospital. The present study helped in assessing the impact of healthcare management, manpower, operational effectiveness toward the optimal service provision for screening of DR in rural India, its effectiveness, financial sustainability, quality of service, evaluation, monitoring, and further follow-up of the disease. In order to tackle the rising problem of avoidable blindness due to DR in developing country like India, such DR methodology can be streamlined in the rural population. Future planning are monitoring and pre- and post-training evaluation of the intervention done, reflection, follow-up, and more robust use of teleophthalmology, AI, and inclusion of machine learning for the screening purpose. Thank you so much.
How is your model different from all others like Shankar Nathralaya, LVP or Chitragood or any other? How is it different?
Sir, as I said that AIOS task force, all this methodology has been mentioned that you can use these things. But we have intervened with the help of DR online software we used. We provided tabs to all the healthcare facility where these were used by the NCD staff. And the online entry was done, and internet was provided with the dongle, and all these photographs were transferred and were taken by the healthcare profession, not by the ophthalmic surgeon. These were done by the paramedical staff and referred to the base hospital. We done it, the ophthalmic surgeon screened the photographs and sent the report, then the patient were referred with the help of the paramedical staff and the health workers. We compared this comparison of the screening by the ophthalmic surgeon with AI softwares. How much the AI software is helping out the success of the AI to detect, that is the mild NPDR, which is detected by the ophthalmic surgeon, or a PDR or advanced PDR.
Thank you, Dr. Asar Mohammed.
Thank you.
So we will go to the last presentation. Dr. Nikita Gupta will give a talk on RP tears to inject or not.
Good morning, everyone. The topic of my presentation is RP tears to inject or not. One of the rare and more dreaded sequelae of CNVM are RP rips or RP tears. So we did a retrospective observational study of 5 eyes with spontaneous RP tears or those formed following anti-VEGF treatment and looked at their management over 1 year. 5 eyes of 5 patients were taken, OCT confirmation of the tear was done, intravitreal anti-VEGF agents were given in all these patients and the response assessed over a minimum period of 1 year. Coming to my first case, it was a 64-year-old female who presented with diminution of vision in her right eye with a BCVA of 6/12. She had a large PED with a height of 503 microns and a basal dimension of 2860 microns. She also had some subretinal fluid. The patient was injected with injection Eylea, and 1 month later, the patient's vision, although improved to 6/9 parts, however, we could see a clear-cut area of RP tear just falling at the fovea. You can see this area of bare choroid and the RP scroll at the fovea. The patient still had some SRF and the patient was re-injected with Eylea. However, this time the visual acuity did not improve. It was 624. However, there was no fluid. The patient did fine for next 3 months, again, after which she again developed fluid, and again she was injected with Eylea, and her visual acuity came back to 624. And this same happened in December. After 2 months, she again developed fluid. We re-injected, and at the end of 1 year, her visual acuity actually dropped from baseline 612 to 636. As you can see, the RP tear was just at the fovea and there is some scarring also underneath. So from this case, we learned that although every time fluid came, we re-injected the patient and the patient did improve. However, if the RP tear is involving the fovea, vision does not significantly improve with treatment. Coming to my second case of a 60-year-old male who presented with diminution of vision in his right eye since 2 months. The patient's BCVA was 6/60. There was no history of any injection of anti-VEGF or any laser done. We can see an area of RP scroll with an area of bare choroid on either sides of the RP tear, and the other side had drusen's. You can see the area is better appreciated in autofluorescence. There was a lot of SRF and IRF, and we injected the patient with Eylea. And 1 month later, the patient was very happy, and the visual acuity improved to 6/12. And the fluid had nearly gone. There was some SRF. We re-injected. The patient was maintaining 6/12 for the next 3-4 months. After which, again, he developed the SRF and IRF. We re-injected the patient. However, this time, although the fluid disappeared, the visual acuity had actually dropped down to 660. Probably this is secondary to the scarring that has happened underlying the CNVM complex. Even though the RP was intact under the fovea, the scarring had led to a drop in vision. We can see the scarring under the RP as well as in the area of bare choroid as well. At the end of 1 year, the patient had a visual acuity of 660. That is a drop from the baseline. So from this case, we learned that if the RP rip is not involving the fovea, vision is usually not affected till the time CNVM's complex starts to scar. However, every time if the fluid is resolving with treatment, we should treat the patients with anti-VEGF agents on a PRN basis. Coming to my third case of a 77-year-old male who presented with diminution of vision in his right eye for 1 month. The BCVA was 6/9. You can see a large PED, some SRF and IRF. The patient was injected with Eylea. The patient had improvement in visual acuity 6/6. However, there was some hyperreflectivity under the fovea, but no clear-cut RP rip. However, 1 month later, the patient had again an RP rip falling just short of fovea. The visual acuity was maintained to 6/12. You can see the area of RP rip. There's bare choroid in this area. It was confirmed on angiography as well. The patient was injected with Eylea. 1 month later, the patient, after the effect of the Eylea probably subsided, the patient developed fluid. But every time we injected the patient with Eylea, the patient's visual acuity remained 6/9. There was fluid, but it never increased. However, this time there was fluid on the nasal side of the RP rip also. We gave the injection on 24th June, and just 1 week later, we repeated the OCT just to find out whether the injection is actually working. And we did see that there's a small slight decrease in the SRF on either sides of the RP rip. And 1 month later, the patient again developed a recurrence of fluid, and we again re-injected the patient. However, we kept increasing, the fluid was never reaching under the fovea, and every time we kept increasing the interval of injections from 4 weekly to 5 weekly to 6 weekly, and then ultimately this patient has been on a 2.5 year follow-up and is now on 8 weekly injections, and the patient has been maintaining a visual acuity of 6/9. So from this case, we learned that RP rips usually tend to move towards the fovea, and once they form, they usually don't extend further. And if the fluid is not resolving completely but is remaining stable, we can actually switch to a treat and extend regimen. I'll skip my last case. It's just a RP rip involving exactly the fovea, and the patient's visual acuity was finger counting close to face after an injection of Eylea. And at the end of 1 year, the patient did not improve very significantly because the RP rip was involving the fovea, but did maintain his vision. So, and so out of my all 5 cases, 3 of them, that is 60% of cases, had a visual acuity improvement or stabilization at the end of 1 year, while the visual acuity worsened in 40%. Worsening of visual acuity occurs when RPTs either involve the fovea or when scarring develops under the CNVM complex under the RP. So the take home is that do not always treat at all in bullous PED if it is threatening but not involving fovea, as these cases are at high risk of developing an RP tear and vision might be permanently affected. However, if there is fluid and you have to treat at all in bullous PED, anticipate the chances of an RP tear and explain that to a patient. More importantly, it is important to identify when an RP rip occurs and prognosticate the patient accordingly. And as long as vision improves or remains stable and there are persistent exudative changes noted with the RP tear, do not hesitate to inject further anti-VEGF injections. Thank you.
So what should be the cut limit of visual acuity? As in one case here, the previous pre-injection vision was 6/9. Yes. And after the injection, the rip occurred and the vision dropped to 6/12. And patient must be complaining in those cases.
Now, actually, I don't feel that there's a cutoff of visual acuity. As long if the RPT has already occurred, then you have to explain the patient that the visual acuity might not improve even.
It means the pre-injection counseling is very important.
Yes.
In where you have a big
wherever there's a
PED,
tall bullous PED,
bullous
just
PED.
anticipate an RPT and explain
what is the take-home message from you? You are telling that even if there is RP rip, you have to continue injecting.
Yes, sir.
Then in the conclusion you have written, large PED where there is a risk you should not inject. How can you conclude that from your 5 cases already
So I'm saying if there is a tall PED and it is not
that is
involving
not a
the
conclusion from this study. That's a general conclusion. So
It's
this
a
is
literature conclusion.
literature
Yeah, it's
conclusion.
literature.
That is still controversial.
So any cutoff points you use as a visual acuity?
So not for
For
visual
injecting-
acuity, but basically literature says that if this is the PED height is more than 500 microns, or if it's a recent onset PED less than 4.5 months history, or if the greater basal dimension is too much, there's no cutoff for that. For height, there is 400 microns. Then you should anticipate, and if these are high risk factors, and
If the vision is 6/9, should you inject or you should wait?
so if the patient, if that's what I'm saying, if counseling is very important. If the patient understands that there is a chance
I
of
think we
and
are
he's ready-
deviating from actually the message of the study is you have to keep on injecting even if there is RP.
Should not
Not
quit
the
dosing.
yeah, that is. So anyway, thank you, madam. Anything?
Ma'am's the question.
Subhadra madam's comment will not be counted for mark. Don't worry.
So Mark, just to have what I do, we have published also that these tall PEDs we should treat with oral steroids for 4 weeks. Everything flattens, and then you can inject. Never inject with that big PED, because if you don't inject, the CNVM will worsen. But you give them steroids 4 to 6 weeks, everything goes away. Even nowadays I give IVMP for 3 days, and then few weeks of oral steroids. Everything goes away, whether it is PCV, whether it is hemorrhagic PED, anything. They really do well. And this is based on the histopathology of some of these eyes, which was published way back in 1970s by Green from Johns Hopkins, that there is inflammation in these eyes. We already know there is inflammation in CRVO, we are giving Ozurdex. So even these eyes, they have a lot of inflammation, give steroids, you will see dramatic change in your outcomes.
Thank you, madam.
Ma'am's remarks are learning remarks for all the audience.
It is
So the
published.
next,
Thank you. Thanks.
the next talk is latest screening by Kanika, Dr. Kanika. Guest talk.
This is a guest talk. I think the next session people are already here, but unfortunately we started at 8:35. That is why.
Hi.
A very good evening, a very good morning to everyone. So this is a very basic talk on how we are managing retinopathy of prematurity in a tier 4 city. And we are doing screening and treatment in a place in Uttarakhand, which doesn't have a retina surgeon around 100 kilometers from our center. And we have still attempted to treat and screen patients. So I would just like to share with you how we are doing it. I would like to thank Have a Heart Foundation, Narayan Netrale, and Dr. Anand Vinekar. Okay, so we all know what ROP is. It's a miserable disease of the premature children. This is how it's classified. So the screening modalities, we screen a baby who's less than 2 kgs of weight, less than 34 weeks prior if he's born, or any other systemic factor. So traditionally, it's indirect ophthalmoscopy, and the latest is photo documentation. Technique for both is the same. Pre-examination, 45 minutes prior to screening, we have to dilate. And this is how the conventional indirect ophthalmoscopy is done. And this is I don't have any financial disclosures, but in the current Indian market, we have the Forus Neo camera. And this is a very, it's a mobile camera. It's very easily transportable. And this is what the camera looks like. And it comes with a laptop. The benefit of photo documentation is the ophthalmologist is free to multitask, especially in tier 4 cities like me. We have other things also, so we have it's easy for us to do other works also. It's a quick and painless method because we don't need to depress. Hence, lesser staff is also used. Lesser litigation charges because we have proof, and we can have multiple consults with experts. So this is how this boy travels with this small camera in the attached case, and this is our van, which he takes around 100 kilometers every 1 day in a week. So this is the video. This is how small the camera is, and it has the entire camera and the laptop, everything inside it. This is how the examination is done. So I think there is a little bit of a glitch in this thing. So maybe I will just show it from here. So this is just how the examination is done. Okay. Okay. Yeah, so and this is how the pictures are stored. I will just go back to my presentation. I need to go back to the PPT.
Actually should see late, but
आगे नहीं जा रहा
कुछ नहीं है स्टेपलर वगैरह है
क्या बोला
हाँ glue says हाँ we'll go to the office
ये है PPT
glue वगैरह है कुछ seal करने के लिए टेप भी चलेगा
So the treatment considerations. So this seems like a very difficult or algorithm, but the basic thing is that we follow up between 1 week to 2 to 3 weeks up till it needs treatment, and treatment is basically historically it's always been the laser therapy, and we go in for treatment when it's any stage zone 1 with or without plus disease, and zone 2 stage 2 or 3 with plus disease or AROP. Now we've started giving for quite some time now anti-VEGF therapies also in AROP. So this is one image of us injecting a baby, but it was so difficult to actually take a video. So it's not very clear. But it just has to be the usual, in adults it's usually between 3 to 4 mm. This is just 1 millimeter from the limbus. And if your needle is 4 mm, you can go till the hub. If it's 6 mm, then you go halfway through. Go absolutely straight because the lens is more globular in the child. This is the other eye. We really tried hard to get a better video, but it was. And we don't push the plunger ourselves. It's the assistant who actually pushes the plunger, because both our hands are busy. Okay, this is the pre and post injection images. This is around 3 weeks after this. We had to laser the patient because of PAR. It developed PAR later. Laser photocoagulation is done because it targets the avascular retina. This is where we do the laser. We try not to anesthetize the child, but in case the child becomes a little bigger, then it gets very difficult to do it without anesthesia, then we are forced to do it. Okay, so these are the pre and post laser images. And we don't have a vitrectomy and scleral buckling facility in our center, so we send our patients over to Narayan Nethralaya, Bangalore. And this is one of our patients who was sent over. This is operated by Dr. Sushma Jayana. And he was grade 5, the child. can see the detachment here, the fibrovascular proliferation. We had lasered the patient and then sent the child over, but okay, this is the pre and post vitrectomy images. So post-treatment considerations are basically frequent follow-ups, refractive error management. The patient can develop amblyopia and strabismus, and of course the parents need to be screened very well. Thank you.
Yeah. So we conclude this session. Any speakers are there, presenters? We can come forward for a photograph.